Hello everybody, I'm very happy to present today this technique about functional UKA with the Corey system. Let's talk first of all about the patient. It's a classic medial osteoarthritis without any other lesion. The setup, I like to have the knee in full extension and then with the first support 90-degree of flexion and with the second support a full knee flexion. That allows me to do everything I want. Concerning the approach and navigation landmark, there is a kind of safe distance in between the tracker and the knee, and I like to have at least 10 centimeters for that distance. Inserting the tracker is quite classic. You can start by the femur or by the tibia. It's not very different, and just control to be bicortical to have a strong fixation. Then you control that you have everything included in with the system in full range of motion. My classic approach for the uni is a mid-vastus approach. So I like to see everything I can do. So I do exactly the mid-vastus approach inside the vastus medialis onto the tibia, and then I open that space to see the medial compartment. It's not a release, you can see, it's just opening the door until I see the meniscus and I can remove it, and I have a full visualization on the medial compartment. Then this retractor gel P is quite useful to have a classic visualization. Then the checkpoints. First of all, I control the femoral checkpoint, then the tibial checkpoint on the tracker, medial malleolar, then lateral malleolar, then the center of the hip. Keep in mind that you have to do rotation and not translation. It's very important to understand. Then you check the actual deformity, and you have to push to stimulate the stand position to have the neutral position of the leg. Then the full of motion, range of motion, and you know the varus, valgus, and you know the range of motion at that step, full weight bearing. Then you can control if this varus is reducible or no using this ligament tension, and you can see on the screen the possibility, the laxity you can measure with this constraint. You have to do it several times to be sure to clearly record everything. Then the point of interest, first of all, the knee center, then the end of the most distal point, the posterior point, you have to go in full flexion. That's why the second post is very important. Then you draw the femur, and you don't have to draw only the space in which you want to put the uni, you have to draw all the femur, and so you can decide exactly where you can put the prosthesis into that knee and not only into that condyle. Then the tibia, knee center of the tibia, low point, most posterior point, and you have to put some valgus constraint to have an access to the posterior border, most medial point, and then once again you draw the knee. Keep in mind that if you have external rotation and valgus, you can go very posterior. This is the most difficult part to do, to have a clear access at the posterior aspect of the tibial plateau. Then you plan, and you can control everything. You have your own screen, and you can decide whatever you want. The size, you can modify the position in every plane of the space. I like to do that to reshape the distal femur at that step, to control that the prosthesis is not too big, it's not in contact with the femoropatellar part of the knee, and that is well centered, and you can control with the rotation at the left and down, and you have to control the classic view on the transversal view at left and top. So here I decided to decrease from one side and to reshape directly. Then for the tibia, first of all, my advice is put it as anterior as you can. You can decide to use a size bigger than the one you will use at the end, because you will choose definitely the size once you be there. Then you control what you did, and you try to have a linear aspect of the space in between 1 and 2 millimeter gap, between 0 and 1 and 2 millimeter gaps, not more than that. And you can see that you can check everything. I like to not resect too much on the tibia. I like to keep the varus deformity, and then after you control the point, and all the point I align each implant. You recheck the femoral trachea, and same for tibia. And if everything is all right, just have to cut the bone, and it's quite easy. My advice here is just to check and look only the screen, and you follow the screen directly without looking at the knee. You can protect by using that device that is for the trachea. For the femur, as you decided the size, you can drill the hole immediately. And you need also to have a full flexion, as you can see here, to go very posteriorly and to remove everything. Then you drill the hole by removing the distal part of the burr. Now the time is the tibia removing, and you do exactly the same with the same tip and tricks, and just follow the screen. My advice here is not to drill the hole at that step, because you are not sure of the size. And the second advice is to have to be very careful to respect the right angle you have at the lateral part of the tibial plateau you just created, and you have really to remove everything and make that plan at 90 degrees. Then you create the space to insert the prosthesis, and you can check and control with trial implant. I try to have as much couverture as possible without overhang. Then you fix it progressively, you drill. Now you know the size, so you can ask the nurse to give you the size. Then the polyethylene, then the femur in full flexion. Here we are, 90 degree impaction of the femur. And now the checking. You control if there is no impingement with the patellofemoral, the full range of motion. You try to see if the line on both implants are parallel all the time, and if the contact point is very soft everywhere. Then you can check the gap balancing using the unique system, full range of motion and not too much of laxity. Then the implantation, I control the hemostasis, final implantation with cemented implant. Start by the tibia. You can impact it with this special device. And you have very nice tool to remove the cement, particularly the posterior part. This one, and also a curette designed for that, very easy. Then the polyethylene, then the femur, as the same way as you did for the trial implant. Impaction and 90 degree of flexion. We move all the cement, and then the final checking. full range of motion, ligament tension, and clinical evaluation. It means that implants are in good contact during all the range of motion. Easy and soft. Then the wound closure. First of all, the capsula. Then the subcutaneous tissue. And I will close the skin with glue to be very minimal in the care that will be provided after the surgery. This step of the closure is very important, and then really I recommend the use of the glue, which is really a game changer for patients. Here we are, the glue that covers the skin. You don't have to do anything special, and it will disappear with the desquamation of the skin. This is the final X-ray. Process in good position. Thank you very much, and keep in touch.